Welcome to you all to this ADVAC Alumni webinar. Today we're going to talk about dengue. As you all know, there are big outbreaks occurring those days, and we thought it would be a good opportunity to talk not only about the disease itself, but also the vaccines. And for that, I'm very pleased to have as the chair of this webinar, Anna Durbin. That many of you know. Anna Durbin studies experimental vaccines for SARS-CoV-2, dengue, West Nile, Zika, malaria. She worked on human clinical trials and controlled infection studies. She worked at the NIH and then is on a tenure track at the faculty on the Department of International Health at Johns Hopkins School of Public Health. She's a professor of international health and the director of the Center for Immunization Research. She's served as a PI in more than 30 clinical trials to evaluate the safety and the immunogenicity of various flavivirus vaccines. And she more recently worked on a dengue live attenuated tetravalent vaccine that is going through an ongoing evaluation in Brazil, Thailand those days. So Anna, I hand it over to you and your guests for this webinar. Thanks a lot.
Oh, thank you very much. It's my pleasure to be here. I have to say, after all of that introduction, Kamel, the one thing that's not in there is I was never a student at ADVAC, which greatly disappoints me, but I'm so lucky and to be able to teach every year there. So I get to sit in on all of the lectures, which is just wonderful. I've learned a tremendous amount. I want to say we have some fabulous speakers today as well. We're going to start with 2 talks, and then we're going to have a panel discussion followed by opening it up for questions. So it's really my great pleasure to introduce João Bosco Siqueira, who is going to be giving us an update on dengue epidemiology. Dr. Siqueira is from Brazil. He has an MD, MSc, and PhD in tropical medicine from the Federal University of Goiás, and he's associate professor at that university. I met João when he was advisor to the Brazilian Ministry of Health. He was there between 2000 and 2016 when I was working with Butantan and a dengue vaccine. He was so helpful to us, and it's really great to have João here. He's currently researching areas of epidemiology and surveillance of communicable diseases, dengue, and other arboviruses, and investigation of outbreaks and epidemics. So he's been very, very busy this year with the dengue outbreak. Our second speaker is also a good friend of mine, GabrielaPaz-Bailey, who we met, of course, over dengue. I've met so many good people working on dengue, and it's really our pleasure to have Gabriela here today. She's a medical epidemiologist at the Centers for Disease Control and Prevention and is currently the chief of the dengue branch in the Division of Vector-Borne Diseases and the National Center for Emerging and Zoonotic Diseases in San Juan, Puerto Rico. She completed a degree in medicine and surgery at the University of San Carlos of Guatemala. She continued her graduate studies at the London School of Hygiene and Tropical Medicine in London, where she pursued a Master of Science in Tropical Medicine and International Health and a PhD in Clinical Epidemiology. She joined the US-CDC in 2000 as an EIS, or Epidemic Intelligence Service Officer, and she has more than 2 decades of experience in public health and epidemiology in the United States, Central America, Africa, and Asia. She studied the natural history of several infectious diseases, focusing on their acquisition and response to therapies. These include tuberculosis, Chagas disease, HIV, hepatitis B and C viruses, herpes viruses, and of course, arboviral diseases such as dengue and Zika. Her most recent work includes the implementation of dengue research cohorts and enhanced surveillance, and obtaining advisory committee on immunization practices recommendations for the first dengue vaccine approved for use in the United States. And it's really a great pleasure to have Gabriela here, who is a graduate of ADVAC. So she's come back to share her experience with everyone. And next, we're going to have on our panel Dr. Jacqueline Dean, who has more than 20 years of experience in infectious diseases and research. After obtaining her medical degree in the Philippines, she completed her pediatric residency training at the University of Nebraska Medical Center and pediatric infectious disease fellowship at the University of California, Los Angeles Medical Center. She obtained a master's degree in public health in developing countries at the London School of Hygiene and Tropical Medicine, and she's worked at the Vicente Sotto Memorial Medical Center in Cebu, Philippines, the Medical Research Council in the Gambia, the International Vaccine Institute in Seoul, Korea, and the Menzies School of Health Research in Darwin, Australia. She's currently an adjunct professor.
You're muted, so we couldn't hear the last part.
Oh, I'm sorry. I don't know how that happened. Dr. Dean's worked at the Vicente Soto Memorial Medical Center in Cebu, Philippines, the Medical Research Council in the Gambia, the International Vaccine Institute in Seoul, Korea, and the Menzies School of Health Research in Darwin, Australia. She's currently an adjunct professor at the University of the Philippines, Manila, where she's an investigator of dengue studies. And I wanted to say that Dr. Dean brings great experience from the Philippines with the experience of Denvaxia and introduction of dengue vaccines in the Philippines. So I think we're going to have really a fantastic discussion when the panel convenes after the talk. So now what I would like to do is turn it over to Dr. Siqueira, who's going to give us an update on the expanding area of dengue epidemiology and just giving us insight into the extensive outbreak of dengue throughout the world this year. Thank you, João.
Thank you, Anna, for the invitation. Thank you, Kema, for the invitation. Thanks, ADVAC, for this opportunity. Well, I must say that I have read an unhealthy amount of reports and bulletins to put this presentation together, so let's start. I believe you all are now seeing my screen, so let's go. Well, I've been discussing dengue epidemiology with most of the companies developing dengue vaccines for the past 15, maybe 20 years. And basically, I have one conflict of interest. I have dengue. I have had dengue before, so we can't just forget it. Well, dengue is a flavivirus for distinct serotypes. It's a public health problem in over 130 countries. There's no specific treatment for the disease. We estimate between 100 and 400 million infections every year. And we have seen a tenfold surge in reported cases from the 2000 to 2019, from 500,000 cases to 5 million cases. And the disease is spreading to new areas, including Europe, and it has a really high economic burden. We have almost 4 billion people living in areas of risk right now. We're not talking about dengue only these days. We have more urban arboviruses like chikungunya, dengue, fever, and Zika. And in the blue map, in the countries in blue, you can see countries that have at least 3 of these viruses. And as you can see, it's most of the world. And we have seen this increase in the number of deaths due to dengue, especially since mid-2000s, and especially here in the Americas region. So let's start. I'm gonna touch 3 different topics. How are we now? Who's getting sick? And the deaths. So how are we now? We are coming from a really bad year in 2023. More than 6 million cases reported, more than 7,000 dengue-related deaths from 80 different countries and territories. In the Bajo region, in the Americas region, over 4.5 million dengue cases, over 2,400 deaths. In the Southeast Asia, a 5-fold surge in Bangladesh, 3-fold surge in Thailand in 2023 compared to 2022. At least 10 countries reporting dengue in the Middle East. In the Western Pacific region, 8 countries reporting dengue, mostly in the Philippines and Vietnam. Autochthonous transmission in France, Italy, and Spain, very few cases, but still it's a trend. And 12 countries reporting dengue in the Africa region. And for instance, this is the data from Bangladesh last year. I mentioned that they had this five-fold increase. So it was a really bad year for them. But it was until 2024. 2024 is something different. It's overwhelming. And as you can see in the first 3 months of the year, we have seen a lot of dengue cases around. And I'm going to show you some of this data. So we have seen it in the news, in the Americas, in Asia. Dengue has been all around. And let's start with the Americas. In 2024, we have already had more than 5 million reported cases this year alone. 2023 was the worst case until this 2024 season. So in the first 3 months, we have more cases than 2023, the whole year, and almost 5,000 severe cases, almost 2,000 deaths already. And if we update it, it's well over 2,000 deaths at this point. So it's shocking to see this increase in dengue transmission in the Americas region. We have never seen anything like this before, and I'm going to show you some of these countries with this outbreaks, unprecedented outbreaks. So if we take the countries in red in this map, they concentrate around 97% of the cases in the regions, mostly in Brazil, but also in Argentina, Paraguay, Peru, and even in Mexico. When we look at the dengue epidemiology, we know that there are some countries that they have this very well-established seasonal pattern. And it's the second semester for the North Hemisphere. But take a look at this data. Even in Mexico, we have seen an increase in dengue transmission in a non-seasonal period. And the same thing happens in Cambodia. Again, they have this well-established seasonal pattern for the second semester, and this first semester, we are seeing lots and lots of cases. In Peru, they had the worst outbreak ever in 2023, and right now, they are basically at the same level of transmission in 2024, with over 79,000 reported cases and 82 deaths. When we look at Colombia, Colombia is way above their epidemic threshold, which is the red line. So again, more than 100,000 reported cases up to epidemiological week 16. And Brazil, I really can't make sense of this situation. We were coming from consecutive years of at least 1.5 million probable cases, and right now we had 4 million probable cases in the country. Even without a shift in the predominant serotype, this is overwhelming. I'm sure that we are seeing some over-reporting. There's a lot of dengue cases, but there are also a lot of chikungunya cases, maybe other diseases. The MOH in Brazil is working, trying to figure that out, but still, it's an overwhelming dengue season for our country, and we have basically 2,000 deaths already. This is the numbers for yesterday. Argentina was a country free of dengue until this recent years. And again, they are having their worst epidemic ever this year in 2023, 2024. So who's getting sick? And it varies between the countries. When we look at countries like Paraguay, Colombia, and Mexico, we're going to see this huge amount of cases in older children, adolescents, and very young adults. So this is a pattern that we have here in the Americas, but we also have countries with different profile. We have Brazil and Peru with more cases in adolescents and young adults. When we look at the Dominican Republic, it's mostly the adolescents that are being affected by the disease. And when we come to Asia, in Thailand, for instance, older children, adolescents, and young adults, they had the most cases and the higher incidence. And the same thing for Sri Lanka. But for Sri Lanka, the data is for 2017, and this is from a systematic review published for Thailand. And finally, what about the deaths? That's very tricky. We don't have a lot of information out there with the characteristics of people dying from dengue over time. So when we look at Peru, we're going to see adults and mostly the elderly dying from dengue in these recent years. When we come to Malaysia, we're going to see that mortality is higher in adults, but we also see deaths in children, in the elderly. And Brazil is a very large country. So we see different deaths profile within the country. In the north and the northeast, we are seeing more deaths among young adults. And in the south, central Brazil, and the southeast, we see a different profile with deaths mostly concentrated among the elderly. So it is very challenging for the health systems to deal with this scenario. We need to prepare for dengue deaths. The profile is different between the countries, and we need to be aware of it. But we still need some better data, especially on the deaths, so we can move on with our preparation for the future outbreaks. And finally, I have some final remarks. There is this increasing trend of dengue transmission throughout the world. 2024 is the worst year up to date, especially for the Americas region. We are seeing this high burden in older children and adolescents, both in the Americas and Southeast Asia and other regions of the world. I'm not sure what to say about the deaths globally. We have seen deaths in children, in South America, at least in the elderly, but it varies between the countries. And there's something new here. The Americas were basically free of this massive dengue 3 circulation until 2022. In 2023, most of the countries in the North Hemisphere, in the Americas, they shift from dengue 1 and dengue 2 towards dengue 3. But dengue 3 has not been around in South America since 2009. So it means that, okay, we are having this huge outbreak this year in South America, still with dengue 1 and dengue 2, but we may shift towards dengue 3 with 15 years from the last time dengue 3 circulated. So we may see another really bad dengue season in 2025, maybe 2026, as soon as dengue 3 starts to circulate in South America. And we have this scenario. We're going to see a discussion about vaccines soon. And some countries have already started using the new dengue vaccine, and especially Brazil. And right now, we are aware that we have this huge amount of fake news and everything. And we need to be very careful with the vaccines because the rumors are going to start. We have at least three different arboviruses circulating in urban areas. We're going to start seeing people saying that, oh, I was vaccinated and I got dengue, but was it really dengue? Wasn't it chikungunya? Wasn't it Zika? Wasn't it something else? So we need to improve surveillance towards this better diagnosis, especially after the vaccine introduction. And I think that as my final comment, we need to be really good with the objectives of our immunization programs. We need to communicate better. We need to better understand the rumors and address these rumors in real time so we can assure that the truth is out there, that we are communicating the real information to the population and regain our credibility over time. Thank you.
Thank you so much, João. That was a wonderful talk. And I think we're going to come back to some of these discussions in our panel discussion. But I'd like to turn now to Dr. GabrielaPaz-Bailey to give us an update on dengue vaccine. So take it away, Gabriela.
Great. And I hope you can see the slides in presentation mode. Thank you, Anna, for the kind introduction, and thank you to the organizers and for ADVAC to inviting me to present today. This is my disclaimer, and in the next 15 minutes, I'm going to review concepts on dengue that influence vaccine development, and then the 3 vaccines that are either approved or in late stages of development. And one of the most important challenges in a dengue outbreak is that the healthcare systems can become overwhelmed by the number of dengue patients. And these images were taken in Honduras, in Central America, but they're representative of dengue outbreaks around the world. So while you listen to this talk, I would like you to think about how vaccines could help us change the way we do dengue prevention. And as you already heard, dengue is caused by one of 4 distinct but very closely related viruses. Infection with one virus gives lifelong immunity to that specific serotype, but only short-term cross-protective immunity to the other types. And the sequence of dengue infections is an important risk factor, with the second infection with the dengue virus being the riskiest for severe disease. This figure illustrates the differences in risk for severe disease based on the sequence of exposure to dengue viruses. The blue arrows indicate the sequence of exposure, and the color of the people indicate the level of risk for severe disease, with green as low risk, yellow as medium risk, and red as high risk. The person in this image is exposed to different wild-type dengue viruses 4 times in their life, as shown in the 4 blue arrows with a mosquito in them. And a child living in an endemic area is usually infected multiple times before adulthood. So the first exposure is usually medium risk for severe disease, represented by the yellow person, but the second exposure is the highest risk for severe disease, shown by the person in red. After this, the third and the fourth infections are low risk for severe disease. So the reason for the differences in risk based on the sequence of infection is explained by antibody-dependent enhancement, or ADE. And in ADE, the lower heterotypic antibody titers that were developed after a first infection are ineffective at neutralizing the dengue variants from a second heterotypic infection, but they can facilitate entry into circulating monocyte cells. And these will result in higher viral loads that lead to increased NS1 production, increased permeability, and plasma leakage and severe disease. So in summary, for this first part of the talk, dengue pathogenesis has implications for dengue vaccines. The dengue vaccine must protect against all 4 dengue serotypes, and vaccines may provide short-term heterotypic protection, but a long period of observation following vaccination, maybe from 2 to 3 years, is needed to identify immune enhancement in the context of waning cross-reactive immunity. So before I get into the details of each of the 3 vaccines, I would like us to think about what characteristics we would like from an ideal dengue vaccine. Efficacy and safety are the most important part of this ideal profile. The biggest risk with dengue vaccines is enhanced disease due to imbalanced protection. Then we would want to see significant protection in seropositives for all serotypes combined, as well as against each individual serotype. And then we want to see the same efficacy in seronegatives, both for all serotypes combined and for each individual serotype. In terms of characteristics and recommendations that make it more feasible to implement, it would ideally be a single dose in the primary series. Also, it would be ideal if it could be recommended for everyone, even at the extremes of age, who are often at the highest risk for dengue mortality. The ideal vaccine would not require pre-vaccination screening that I will explain on more detail later, and it would be recommended for travelers. Okay, we will now talk about Dengvaxia. Dengvaxia is a tetravalent live attenuated vaccine that is built on a yellow fever backbone with 4 chimeric viruses for each dengue serotype. It is the first licensed and recommended dengue vaccine, and it's a primary series of 3 doses that are given 6 months apart. So it takes a full year to complete the series. Dengvaxia was developed in the 2000s. The phase 3 trials started in 2010. And in 2015, the trial results showed an increased risk of severe disease in the youngest age group, in the youngest children. In 2016, WHO recommended the vaccine for children 9 years and older. And in 2017, the famous case cohort study showed that the increased risk of hospitalization in the youngest age group that was seen in 2015 was actually due to serostatus, with increased risk of severe dengue and hospitalizations among the seronegative children. So based on this data, WHO revised the recommendations to vaccinate children with laboratory confirmed evidence of past infection. That means pre-vaccination screening is required. So for Dengvaxia, the clinical trials found different outcomes after vaccination among children with and without previous dengue vaccine. Seronegative children had a higher risk for hospitalization and severe dengue if they received the vaccine and got infected later with dengue, while seropositive children were protected after vaccination. And I want to explain how Dengvaxia increases the risk of severe disease among seronegatives by going back to this graphic that I showed you earlier. As I mentioned, in natural dengue infections, the first infection is medium risk for severe disease, the second is high risk, and infection number 3 and 4 are low risk, thanks to broadly neutralizing antibodies induced following recovery from the second infection. So for seronegatives who have their first dengue virus exposure through Dengvaxia, it basically makes their first wild-type infection look like the high-risk second infection, explaining the risk after vaccination. And that is why if you vaccinate someone who has had at least 1 dengue infection before, or someone who's seropositive, you help them skip that high-risk secondary infection and jump straight to that highly favorable low-risk immunological state during the 3rd and 4th exposures. So I wanted to explain this because it will have implications for other dengue vaccines, potentially. But in terms of efficacy in the seropositive 9 to 16-year-olds for whom the vaccine is recommended, Dengvaxia had good efficacy against symptomatic virologically confirmed dengue, or VCD, hospitalization, and severe dengue. It was also protective against all 4 serotypes, with the highest protection against dengue 4 with 89% efficacy. So how does Dengvaxia compare to an ideal vaccine? Well, we can confidently say that it offers protection among seropositives, both in the aggregate and by serotype. It did not offer protection among seronegatives, either for serotypes combined, nor against any of the individual serotypes. In terms of implementation, it is a 3-dose series, and it takes a full year to finish the primary series. It is used for a very narrow age range of children from 9 to 16 years of age. It is not recommended for travelers. And finally, its number 1 limitation is that it requires pre-vaccination screening. Because of the low uptake, the vaccine is being discontinued by Sanofi, and the doses that are currently available can be administered until August of 2026. So beyond this point, this vaccine is no longer going to be available. So we will talk now about a relatively new dengue vaccine from Takeda, TAK-003. It is a tetravalent, also a live attenuated vaccine. It has a dengue 2 virus backbone and 3 chimeric viruses expressing the E and PRM proteins of all 4 dengue serotypes. It has a 2-dose schedule separated by 3 months. WHO SAGE provided recommendations on the use of TAC-003 in September of 2023. The recommendations state that TAC-003 should be considered for introduction in settings with high dengue transmission intensity. They say that countries need to decide what the seroprevalence threshold should be for introduction, but they do suggest minimal cutoffs for seroprevalence to initiate vaccination, about 60% at the age of 9, because this can be an indicator of high dengue transmission. And another indicator could be peak age for dengue-associated hospitalizations in children under 16 years of age. SAGE recommended the vaccine to be introduced to children aged 6 to 16 years of age, and also recommended post-licensure studies to provide more precise estimates of effectiveness and risk against dengue 3 and dengue 4 in seronegative persons. The vaccine application was withdrawn from FDA in 2023, so it's not going to be available for use in the United States. The vaccine has been licensed in several countries, and it's currently being implemented in Brazil as part of their immunization program. So I would like to show you the efficacy data for this vaccine. The per protocol set included 19,000 participants and 27% were seronegative. The primary endpoint was virologically confirmed dengue or VCD due to any serotype. And a secondary outcome was hospitalizations for dengue. And these data are on efficacy at 57 months. So we start with an overall vaccine efficacy for all serotypes and all serostatuses of 61%. Stratified by serostatus, we see 64% vaccine efficacy in seropositives on the left and 54% in seronegatives on the right. When stratified by individual serotype, we appreciate that it has significant positive vaccine efficacy against all serotypes in seropositives, but negative vaccine efficacies with 95% confidence intervals crossing 0 for dengue 3 and for dengue 4. We see a similar trend for the outcome of hospitalizations. There is a vaccine efficacy of 84% against hospitalization for serostatuses and serotypes combined. Stratified by serostatus, there is significant protection in both seropositives and seronegatives. Stratified by serotype, there is significant protection for seropositives, against serotypes 1 through 4. And for seronegatives, there is protection for dengue 1 and dengue 2, and a negative vaccine efficacy for dengue 3 of 88%, and only one hospitalization event for dengue 4 that was in the placebo arm. So this makes the vaccine efficacy difficult to interpret for that serotype. So if we compare TAC-003 to an ideal vaccine, TAC-003 is protective in seropositives in the aggregate and stratified by serotype, and in seronegatives for all the data aggregated, but not by individual serotypes. It was a 2-dose series needing only 3 months to complete. The vaccine was recommended by SAGE to persons ages 6 to 16 in countries with high dengue transmission, and it was recommended for frequent travelers, and pre-vaccination screening was not required. So finally, I would like to mention TV003. It is a tetravalent live attenuated vaccine. It contains attenuated whole viruses for dengue 1, 3, and 4, and a chimeric virus for dengue 2 on a dengue 4 backbone, and it only requires 1 dose. This vaccine was developed by the US National Institutes of Health. It was licensed to Merck in the US and the Instituto Butantan in Brazil, the Serum Institute of India, and others. The phase 3 trials are ongoing in Brazil, and the 2-year follow-up data has been released, and the vaccine dossier will be submitted for review and approval to Anvisa, the Brazilian regulatory agency, before the end of 2024. Efficacy against VCD was 89% for seropositives and 73% for seronegatives, as you can see in the first column. Efficacy was higher for dengue 1 than dengue 2, but at 2-year follow-up, it was still effective for each serotype and serostatus. And during the trial, there were no cases of dengue 3 or dengue 4. Incidence of severe dengue was low in both arms. Efficacy against dengue with warning signs or severe dengue combined was 88% for all groups combined. So how does TV003 fit into this comparison table? For TV003, there was significant efficacy for seropositives and for seronegatives, but we still do not know about dengue 3 and dengue 4. The ages included in the study were persons ages 2 to 59. It will be a single dose vaccine, and we don't know what an age recommendation, traveler recommendation, or pre-vaccination screening recommendation will look like. So in summary, safety is key for all vaccines, but is highly scrutinized for dengue vaccines. Implementing the currently recommended vaccines is important for dengue control. TAC003 post-licensure studies will provide more information on efficacy and on safety for dengue 3 and dengue 4. And TV003 is completing phase 3 trials and may be licensed in Brazil in the next year or so. And I would like to finish with these two lovely pictures of a beach in Puerto Rico and the dengue branch office in San Juan. And thank you so much for your attention.
Thank you so much, Gabriela. I like the rainbow over your office. That's very nice.
Yes, it's a real one.
So if I can have all of the panelists turn on their cameras, I think we can begin the discussion. The first thing that I think I would like to bring up, and Gabriela, you mentioned this a little bit, is just we're having, as João mentioned, this unprecedented number of cases of dengue globally. And we've just learned that one of the vaccines is no longer going to be available. For each of you, I think it would be really important to discuss, particularly starting with maybe Jacqueline and João, the desire for vaccines, the availability of vaccines in your countries, and how you're meeting the demand that may be out there. João, why don't we start with you, and then we'll go on to Jacqueline.
Okay, so the MOH started this year our program. Basically, they stated that they have acquired all doses that were available from the manufacturer. And we started with the vaccination from 10 to 12 years of age, then expanded it to 10 to 14, and now we did it from 6 to 14. But coverage is still low. That's why the MOH was expanding this target group. Not much information around yet, but at least we have started with the program, and then let's see how it's going to turn out. But the challenge is coverage right now.
Mm-hmm. And Jacqueline, I don't know if TAC003 is available in the Philippines, but I'd like you to discuss a little bit the experience in the Philippines with Denvaxia and how that's impacted either demand or availability of TAC003 and any future vaccines that may be coming down the pike.
Yeah, sure. Thank you, Anna. So after the phase 3 trial results were released, Sanofi Pasteur obtained licensure for Denvaxia in several dengue endemic countries, including the Philippines. And in early 2016, the Department of Health rolled out the 3-dose regimen that Gabriela described in 9 to 14-year-old students in 3 northern regions of the country. Then in 2017, this program was extended to Cebu, which is a province in the middle of the country. Then, as Gabriela described, in 2017, Sanofi Pasteur announced the increased risk of severe and hospitalized dengue among the seronegatives, those who had received the vaccine as dengue seronegatives. So soon after, the Department of Health stopped the program and only one dose was offered in Cebu. So this whole, what they now call the Dengvaxia controversy, led to political upheaval, extreme public unrest, and increased the vaccine hesitancy in the population. It impacted routine EPI vaccine uptake, which was associated with measles outbreaks, particularly in the country. So this vaccination rates is just now slowly improving. So as I understand it, Takeda is applying for FDA licensure in the country, but in our discussions with the Department of Health, they're quite cautious about rolling out, understandably, another dengue vaccination program. Perhaps the private practitioners might be more interested in administering the vaccines in their clinic, but in terms of another mass vaccination program, I think that might be less likely.
Thank you very much. And I think that brings my next question for each of the panelists. And that does, Gabriela mentioned very, I think, eloquently about the potential for increased risk of vaccination if we don't have good efficacy or immunogenicity against each of the 4 serotypes. And that requires, that can happen for years afterward and will require very good safety surveillance for years post-vaccination. And I'm curious, we'll start with João and then move to Jacqueline, but does your country, have you instituted, for instance, enhanced surveillance for vaccine-related severe dengue in particular? Most of course, of the vaccine safety surveillance systems are monitoring vaccine safety in, the hours to days to weeks post-vaccination, not for years post-vaccination. So I'm just curious what your health departments, health systems are doing to look for a safety signal, a late safety signal related to these vaccines. João, can you start?
Yeah, this is something that it's routine for us in Brazil. Our immunization program is very well established over time, and surveillance is widespread in the country. We have had some reports on 16 anaphylactic severe reactions after the vaccination with dengue, and but no deaths, and which is monitoring these cases. So far we have this information. I'm not aware if there's a second round of discussion on the severe reactions in the country, but the MOH is monitoring it.
Do they have a system to link, for instance, a case of hospitalized dengue 4 years after vaccination with a particular dengue vaccine? Are those systems linked?
From our hospitalization information system, it's not currently linked with the surveillance system, information system, but it allows us to perform record linkage. So if necessary, we can move on with it. We still have only a few months of vaccination coming into the country, but I'm sure that Fiocruz has established a program in monitoring the efficacy, the effectiveness of the vaccine, and they will be able to do it.
Wonderful. And Jacqueline, I'm wondering, since the experience with the Philippines with Dengvaxia, is there a way to link, for instance, your vaccine registry with hospitalizations for severe dengue down the pike, and even with the hope that we're going to have additional dengue vaccines available in the coming years, a way to distinguish between different vaccines that may have been given?
Yeah, so as João mentioned, like in Brazil, the Department of Health also has a routine adverse events following vaccination program, and this was enhanced following the Dengvaxia rollout. But at that time, it was really hard to tease what was real, in terms of adverse events versus the hysteria that was surrounding the whole event. I understand, though, some institutions like the Research Institute of Tropical Medicine have saved sera from patients who came through who claim to have been vaccinated, which we hope can be used for studies to try to link these issues. The Department of Health also instituted what they call the Dengvaxia lane, wherein children who had received the vaccine could get immediate care in hospitals. But all these programs just sort of went to the back burner when the COVID came.
Mm-hmm.
And at that time, dengue also decreased, like other countries, because of the strict lockdowns. There was very little dengue transmission, and the number of dengue cases started to go up again in 22 and 23, but not quite to the levels that we see in Latin America, perhaps. I mean, just in terms of relative rates. But dengue is highly seasonal in the Philippines, and it usually starts around July until December or January during the rainy season. And it's been a particularly hot and dry, El Nino, with lots of drought in different areas of the country. So it'll be interesting to see what this does to the, for example, the Aedes, and whether we'll see what happens when the season comes in around July.
Oh, thank you so much. And Gabriela, I was just wondering if you could comment on ACIP and their recommendations around Dengvaxia. To my knowledge, there was no special requirement or system to look for, I'm going to say, enhanced dengue illness following vaccination. Do you think that's something that ACIP and CDC will be looking for with the rollout of new vaccines in the US? When and if they come, dengue vaccines in the US, when and if they come?
Yes, thank you, Anna. So the recommendation from ACIP was to vaccinate with Dengvaxia children ages 9 to 16 with laboratory evidence of previous dengue infection. So that meant that we had to evaluate the available tests to detect IgG and identify those that had good performance. And the limits for performance that ACIP and CDC established were sensitivity of more than 75% and specificity of more than 98%. And we found that two tests in combination, a rapid test and an ELISA, provided that level of sensitivity and specificity. There were discussions during ACIP and during the drafting of the recommendations about the needs to establish long-term safety monitoring. And as the previous panelists have discussed, with dengue vaccines, is not sort of the immediate monitoring that happens with other vaccines of the next 24 to 48 hours, but it's important to be able to follow up what will happen 2 or 3 years after vaccination. So what we have done in the case of Puerto Rico, that is the US territory that has implemented Dengvaxia, is that we have been working on first registering the test result in the immunization registry so that we know that only seropositives are being vaccinated, and then making it possible to link the vaccination registry to the case surveillance data. And we're working on strengthening dengue hospitalization surveillance that is in place in the country, but making sure that sensitivity is high. So working with providers. And I think that's going to be needed for other vaccines, but how to do it in practice is challenging because of what João described, that the immunization registry does not really talk to the case surveillance or hospital-based surveillance for dengue, and that these events are so far apart. The other thing is that the risk is small. The increased risk of hospitalization is small. So without knowing baseline sera status, I think it's going to be very hard in aggregate to find even a safety signal later on.
Thank you so much. And I think this also comes to my next question. And that's about how do you implement either Qdenga or, for the time being, Dengvaxia into an immunization program, given that we have, as João reported, the epidemiology is different in many different regions of the world, in many different countries within a particular region. So how does that affect your implementation program? And I'll go to you, João, with your experience with Dengue in Brazil. How is that two-dose schedule implemented in Brazil? And then how do you see that sort of affecting implementation strategies in other parts of even Latin America, where the incidence may differ by age from that seen in Brazil, as you showed in your slides?
Yeah, that was Anna. When we think about any immunization program, I think that we need to first establish what's the objective of this immunization program. Is it to reduce deaths? Oh, so for Brazil, we should be vaccinating the elderly, but the vaccine is not licensed for the elderly in the country, at least in Brazil. In other countries, it's available, but not for Brazil. So we try to identify the higher risk population for hospitalization, and the MOH did this analysis, and they chose this older children and adolescents because of this high rate of hospitalization. So that's why they established this group. Are we gonna see impact with this initiative? Not in the near future. It's gonna take us several years to establish a large amount of people protected against the disease so we can see impact. So I would say each country needs to define their objective. And I know there are very few doses around at this point, but that shouldn't be a reason to do something different. We need to establish the objective and pursue this objective over time. And I believe that that's what the MOH has done here.
That's wonderful. Thank you so much. I want to come back and talk a little bit, and we'll see if our panel can give insight. I mean, we now know that the need for dengue vaccine is huge. The supply is very limited. Is there a place, for instance, for increased public-private partnerships in terms of trying to manufacture vaccines at a higher pace, or support from other entities such as CEPI to really spur on the development either of new vaccines or the ability of different countries to manufacture the current vaccines, should that technology be allowed to be transferred? And this comes back to, of course, the situation with COVID vaccines, where there was, the technology was not really shared, and we had limited manufacturers for some of the most effective vaccines. And so I'm just wondering, you may or may not have information on this, João, but, and looking even at supplying vaccine for Brazil, do you have any indication of when Butantan, even if that vaccine is approved by Anvisa, when they would be able to supply sufficient doses for just Brazil?
I'm not aware of the situation in Butantan right now. We still need the approval, but I can say that Butantan has this amazing tradition of being able to produce a lot of doses at lower cost with other vaccines in the past. So I'm hoping that they'll be able to do it. But right now, it's not possible to say. Maybe someone from Butantan in the audience can make a comment.
Yeah. What about Takeda? Have they given any indication to you when they may be able to provide additional doses of vaccine?
Well, I heard that they were discussing with some countries to improve their production, maybe in India, if I'm not mistaken. But they had these ongoing discussions with the MOH in Brazil. But as far as I know, nothing is down as an agreement.
And maybe
Wonderful.
I can also add, Anna, that it's very important for all of us to consider that having a licensed vaccine is only solving part of the problem. Because even if they're licensed vaccines, manufacturing the needed amounts present huge challenges. And global partners, like, as you mentioned, CEPI, can really help improve access to low and middle income countries, and that can make a huge difference. And I know that for the chikungunya vaccine, for example, they provided funding for 3 companies, and the purpose was to transfer licensure to low and middle income countries and sort of facilitate production in other places. So I think we really need to have that challenge in mind when thinking about vaccines and how they can be available to really change the course of dengue globally. It will require, as you said, public partnerships and the support from these global institutions.
I think I'm going to ask a final question of the panel, and then we're going to move to questions in the chat because we have had some very interesting questions coming through the chat. But one of the thoughts that we had is in the sort of the perfect profile of a vaccine that Gabriela presented and the data in there, and then the reality of dengue where you have different serotypes circulating in different countries at different times. And you know, would your vaccination strategy change dependent on the efficacy data of a vaccine? So for instance, if there were a dengue 3 outbreak circulating, I'm going to ask Jacqueline and I'm going to ask João, you know, do you think that that vaccine, that would affect the Ministry of Health's decision to implement a vaccination strategy given the efficacy data that Gabriela presented and Siqueira has presented? Jacqueline, do you want to start?
Sure. I think this might be relevant for countries with less than 4 serotypes circulating, but for countries like the Philippines, where we have all 4 serotypes in circulation, this is perhaps less relevant. So I'm not sure this would be a strategy that would be useful in our case, because and the serotypes change all the time. You know, right now it's predominantly 3 and 2, but who knows what the next season will bring.
I guess my follow-up question comes to something that João mentioned earlier, is where people are vaccinated in a dengue 3 outbreak and then they still get dengue. Do you think there would be a different communication strategy around that? João, do you want to start?
Yeah, this is a great question, and we need to look at it from 2 different perspectives. Okay, from the endemic countries, we are, at least in Brazil, we are vaccinating older children, and the probability of having a previous dengue infection is higher above 10 years of age. So this shouldn't be a problem because we have data showing that we have efficacy against dengue 3 in previously exposed people. But from the traveler's medicine perspective, that's different. If you're coming from Europe, from the United States, from Canada, or other areas in the world, to areas with a current dengue 3 vaccination, that may be different. But as Jacqueline said, for our endemic countries, it's different. And we still need to monitor, for sure. We still need very good surveillance in place, for sure. But that's the difference between endemic and non-endemic countries.
Wonderful, thank you. So I'm going to move to the questions in the chat, and there's a very good question for the panelists, and I think I'm going to ask the question and then start with Gabriela and then Jacqueline and then João. But the question is, can the panel give their opinion on the possible factors contributing to the fatalities in the Americas? While numerous outbreaks are evident in both the Americas and Africa, particularly now also since January 2024 in West Africa, high fatality rates are not reported in Africa. Do you think that distinct geographical conditions in Africa, such as those influences by other diseases like malaria, could alter the immune response background? If so, how should we consider this aspect as we embarked on malaria vaccination initiatives? I'm going to start with the first part of that question, just to ask, why do you think there's increased number of deaths in the current outbreak in Latin America? Gabriela, do you want to start? And then we'll move to Jacqueline, then João.
Yeah, sure thing. So first, I would like to comment about the surveillance systems, because Latin America has a very robust surveillance infrastructure with the support of PAHO and with CDC. Laboratories have the capacity to do molecular surveillance for dengue. Almost all the laboratories that are part of RELDA, this network of arbovirus labs, have the capacity to do molecular testing, and half of them have the capacity to do sequencing. And surveillance case reporting is present in all the countries. So the numbers in the Americas are so high because there is more transmission, but also the trends are being monitored closely because surveillance is strong. In terms of case fatalities, the region is still below the 0.05 recommended threshold from PAHO in terms of case fatalities. And this is because there is good clinical management training, and there is a system to do reminders for clinical management. There are countries that have not seen dengue recently, like Argentina, that is reporting close to 200 deaths. That seems a large number. I actually don't know what is the case fatality rate. And that may be in part because clinicians there are not as familiar with dengue and recognizing dengue early. In the Africa region, there are several countries in the map that João presented that appear as white. That means that there is no data available. So we don't really know if they're having dengue outbreaks and they're not being recognized. And in many cases, dengue cases could be misdiagnosed as malaria, and dengue deaths being misdiagnosed as malaria deaths. In the case of Burkina Faso, we helped establish enhanced surveillance with laboratory confirmation of cases that came with acute febrile illness. And in 2023, they had the largest outbreak in Africa. So when there is surveillance, dengue is detected and dengue deaths are detected.
Right. Jacqueline, any
So
thoughts?
so in terms of increased fatalities in the elderly, I think one important issue is the occurrence of comorbidities in older people. The literature especially talks about diabetes, but perhaps hypertension can also make it difficult, for example, to manage fluids. Singapore, where they managed to control dengue quite well, they note their severe cases and very, very few deaths, of course, but mostly in the elderly. So I think this is quite an important factor that might be related to fatalities in Brazil. In terms of Africa, this has been a question that's been debated about for decades. And my own opinion is that I think this might be, this is just conjecture, that related to the circulation of the serotypes. Dengue might be a newer infection, for example, in Africa. I remember when I started work on dengue, there was hardly any severe dengue cases reported, for example, from Bangladesh and India. And now it's just, the number of severe cases, or, what they used to call dengue hemorrhagic fever, dengue shock syndrome, has really increased. So this is what my own bias is, but I'm not sure. This is not supported by data.
Thank you very much. Thank you very much. There's another question from the chat regarding antibody-dependent enhancement of infection with dengue. And do we see this with other flaviviruses? And I'm going to start with Gabriela and then João, and I might chime in here too. I have an opinion, but I'm not sure I'm going to express it. So go ahead. Go ahead.
I was hoping you would start answering the question.
If you want, I can start, but you go ahead, and then I'll jump in.
Okay, sounds good. So there are definitely interactions between other flaviviruses and dengue, but the data is not conclusive for yellow fever and Japanese encephalitis. In the case of Zika, this cohort study in Nicaragua has provided important information on the potential enhancement of dengue after Zika infection, measured with levels of antibodies. So just based on antibody response and levels of antibodies, there is potential interaction between Zika and dengue and potential enhancement of dengue after a Zika infection that is a closely related flavivirus.
João?
I'll just look stupid with answering this question. You are the specialist.
So no, I think Gabriela summarized it very well. There were some studies, I believe, from Thailand where the Army cohort there showed possibly more symptomatic dengue illness in people who had received Japanese encephalitis vaccine. I will say I'm not completely convinced about the Zika data yet. I think we need more studies. Most of that was based on modeling. But I think it's a very important question because if there is enhancement from Zika, as we know, it went right through all of Latin America. We do see, and it's interesting, we haven't seen quite the outbreaks of Zika in Asia that we saw in the Americas, but it is a virus that's going to pop up, that's going to be out there. So it's something we definitely have to keep on our radar, and also keep in mind with the surveillance systems that we have in place after these vaccines are deployed. And should we ever get a Zika vaccine in the future? We don't have an interaction between dengue and West Nile virus in terms of enhancement of viremia or enhancement of disease. That was a question in the chat. What we do know, and this is why I think it's very important, that all of the manufacturers did studies and stratified results based on those who had previous dengue antibody, but also in some instances, previous flavivirus antibody, because we know if you've been exposed to one flavivirus, your antibody titers to dengue may be higher. It may make your vaccine look better than it is. So it's always important to do these studies, to study the immune response in particularly dengue naive, but if you have the opportunity to look at flavivirus naive as well, at least early in, not in your phase 3 study, but early on. So we have another question from the chat that I think is good for the panel. How does the panel see the likelihood to successfully develop and implement new antiviral drugs against dengue? Is a specific treatment the best approach to dengue disease? And I think that would be the holy grail, but I am going to ask, we'll start this time with Jacqueline. Do you see a role for dengue antivirals in the treatment of dengue? And my follow-up question would be, how do you see evaluation of dengue antivirals being done?
For me, the most important obstacle for using antivirals in dengue is that you have to give it really early to avoid the immune response that usually happens, around the third day when the patient becomes febrile. So the challenge of trying to capture patients prior to hospitalization to give these antivirals would be one thing. So we did a quick review to look at any antivirals that could be potentially helpful, and there are none to date. There is one that it looks promising, but so far I think that's still, as you mentioned, a holy grail.
Gabriela or João, do you have anything to comment on dengue antivirals?
I think again, Anna, this is a question for you if you want to mention your recent studies.
So yeah, I mean, I think the big problem that we have, and Jacqueline mentioned this, the big problems that we have with dengue antivirals for treatment is that, one, we cannot predict who's going to proceed to more severe disease. And generally, by the time they present and really declare themselves, their viral load is on the decline. So you have to treat people early, which means you would essentially, I think, need to deploy an antiviral at the first suspicion of dengue. And whether or not that's an affordable strategy, I think is a different question. We did evaluate a dengue antiviral as a prophylactic, and it did show good activity, and that's being further evaluated in the field. But I think it would be, I personally don't see, at least for the current antivirals we're evaluating, a role in the treatment of severe dengue because people have progressed so far. So I think it's a good question. I think there may be a role for antivirals in people who can't receive a live attenuated vaccine or other reasons they can't be vaccinated. But I think we're very early, and I think it's going to be a very difficult pathway to develop a good dengue antiviral. So I'm going to ask this question for Gabriela. This is from the chat as well. How is it planned to evaluate immunoenhancement in vaccinees once antibody titers continue to wane?
Yeah, so there, I think is what can be done in very well controlled and well designed trials where you can collect baseline serostatus and follow people in time. And the way to do that is really to monitor future dengue events and hospitalization, severe disease, and the outcomes. In real life, where you do not have the luxury of having a baseline serostatus when implementing vaccines like the Takeda vaccine, I think it's, as I mentioned before, it is essential to strengthen dengue surveillance, including both case surveillance and then strengthening surveillance of hospitalizations. In many countries, case surveillance is separate from hospitalization surveillance, and case surveillance is stronger than surveillance of hospitalized cases. So I think an assessment of how the system works and where the weak parts could be is very important. And the other point that we mentioned earlier is thinking through how to link the immunization registry with dengue case surveillance so that you can understand vaccination status for the reported dengue cases.
Yeah, I think that's excellent. I'm going to ask now, I'm going to turn to both João and to Jacqueline to ask about, we certainly believe that vaccines are going to be sort of a central pillar to control of dengue, but we know that they won't be sufficient alone. And I wondered, João, if you can first comment, because there's a trial going on in Brazil right now using Wolbachia. How do you think that will be incorporated into dengue control? Do you think it will be incorporated, and what do you think the prospects are?
Well, I think that we have this ongoing clinical trial in a really large city here in Brazil, but we also had Wolbachia, the Wolbachia program well established in some other cities, like Rio de Janeiro city. A neighboring city is Niterói, and every time Rio had a dengue outbreak, Niterói also had a dengue outbreak. But the Wolbachia program in Niterói is really well established. So we need to see this. It's not efficacy anymore, it's effectiveness, because it's there. So we will finally be able to evaluate what happened in a really high transmission season in Rio without Wolbachia, and in Niterói with Wolbachia, and move on with this. I think that the near future is based on different strategies and different technologies to prevent the disease. It's not going to be one or another. It's going to be vaccine. It's going to be drugs to use in early stages of the symptoms, as you mentioned. It's going to be vector control with new strategies, because the old ones, they just don't work. They may work in specific areas, but overall, not. So that's it.
Very good. And Jacqueline, has there been any experience with Wolbachia in the Philippines, or any consideration of use of Wolbachia in the Philippines?
As far as I know, there hasn't been. The closest probably would be the cluster randomized study that was published from Indonesia, and there they showed really promising results. I think the question is, the primary question is how long the Wolbachia stays, remains after it's been established, as João said, and if this could be done in the Philippines, that would be fantastic.
Yeah, it is a very, very interesting strategy. There's another question in the chat that's directed toward Gabriela, and it says, have you considered the safety of the different dengue vaccines in people with different comorbidities? And I know as part of the ACIP process, they look at many different considerations in their recommendations. Can you comment on that question?
Yes, and if I may, I just want to also react to the previous question on Wolbachia and vaccines, because I am very optimistic in terms of the future of dengue control with the availability of a strategy that has shown to work in mosquitoes to reduce dengue transmission, and the availability of new and better vaccines. Wolbachia prevents infection, so that is going to lower the immunity in the population, and it's not a perfect tool. So I think it's very important to be able to combine it with vaccines that, as far as we know, are not very good at preventing infection, but preventing disease. And that could really make a difference, I think, in dengue control in the future. So I hope that we start to see programs sort of embracing both strategies. That would be
And I can't remember, just a quick follow, are there any Wolbachia studies in Puerto Rico or planned for Puerto Rico?
Yes, in Puerto Rico, we have worked with Wolbachia suppression. What we're talking about right now is Wolbachia replacement. We're actually supporting an implementation project in El Salvador, in Central America, and we're still in the release phase. So it will take, several years to actually be able to evaluate the impact on cases. But going back to the other question about safety of vaccination in adults with comorbidities, the data is very limited because most of all of the phase 3 studies are in children. And there is some information of comorbidities, but prevalence is lower than among adults. And then from some of the phase 2 trials that have been done in adults, there hasn't been any sort of a signature of increased risk among those with comorbidities. But again, Anna, you may have more information on this.
A Butantan trial went up to people 59 years of age, and we've done some studies in Taiwan in people up to 70 years of age, and the safety profile looks good, but again, that's a limited number of people, and as you know, we may not see signals until it goes into a much larger population, but so far it looks well tolerated. There's a question again in the chat for you, Gabriela. Thank you very much for your talk. Can Takeda provide the data required by the FDA? And if so, when? Will there be a new application for approval in the US?
Yes, thank you. Thank you for that question. I mean, we don't really know all the conversations that happened between Takeda and FDA. What was reported to us by Takeda was that the data that FDA was requesting was not available because of how the study was designed and how the protocol was established. So it does not seem that at least in the immediate future, they can provide the data that FDA requested. And what we understand from the company is that they're going to wait until they have more information on implementation in other places, maybe on the safety study, the post-licensure study that they will do in Asia to apply again to the US. So I don't think that we will have the Takeda vaccine available in the US in the near future.
That's unfortunate. Thank you very much. Let me ask each of the panelists now just to think a little bit prospectively and to think, where do you see the future of dengue vaccines in terms of availability, particularly in the next 3 to 5 years? We're in a crisis mode right now in Latin America and really globally with the dengue outbreak. And if these trends continue, particularly also in South Asia with Bangladesh having a horrible outbreak as well, if you could increase, how do you think we can increase the availability of vaccines? And do you think in a safe manner, because, of course, vaccines have to be safe, but is there anything that we could do, for instance, along the regulatory pathway to accelerate the availability of these vaccines once safety has been established, or at least the potential that we don't have any safety signals? How do you see us really meeting, and I'm going to end with this, each of your thoughts, how do you see the dengue vaccine community really meeting the needs of dengue vaccines? What do they need to help them? And what do you think the prospects are? And I'm going to start with you, João, and then move on to Jacqueline and then Gabriela.
Anna, that's a really hard question because we need
That's why I saved it for last.
Yeah. we need millions of doses. And right now, we just can't meet this demand. More manufacturers, for sure. More vaccines? Oh, it's going to take time. The only other vaccine at this point is Butantan's. But again, Butantan is a single dose vaccine, which helps a lot in trying to get more people vaccinated. And I think that safety is the main concern. It's if safety is established and there's willingness to do it, to improve production in different countries, sharing the technology, we can move forward. But for the next 3-5 years, it's going to be hard. It's going to be really hard. And I still believe that 2025 season, 2026 season may be really hard dengue seasons with changing in the predominant serotypes, especially in the Americas. It's different from Asia. So
Right.
we are about maybe some couple of bad years ahead.
Right. Jacqueline, do you have any thoughts, any magic bullets that we could solve our dengue vaccine crisis?
Certainly not the magic bullet, but based on my experience with the cholera vaccine, the only way we were able to increase production of a safe and cheaper vaccine was through technology transfer to an Indian manufacturer, and also later IVI also brokered a technology transfer to a Korean manufacturer. But then the Indian manufacturer was bought by a large pharmaceutical, and they dropped the cholera vaccine. So we still have a crisis for insufficient number of cholera doses. But I think for the dengue story, it's still worth doing so with Butantan. That's really an important effort. And I understand it's also, the technology has also been transferred to Serum Institute of India. So I think this sort of partnerships will really go a long way in increasing the number of doses.
Yeah, thank you. Gabriela, any last thoughts on this?
Yes, I mean, from the Takeda perspective, I understand that they are opening another factory to increase vaccine production, and they're hoping to ramp up in the next couple of years. I agree with Jackie that licensing, moving the license to other partners is really key. And NIH was very good at doing this and sort of partnered with Butantan in Brazil, with Merck for North America and Europe, the Serum Institute in India, and others in India, as I understand, and other partners in Asia, that I think it's really essential to lower the cost and increase production. And then also the call to our global partners like CEPI. I understand Gabi is considering supporting dengue vaccines, and that can make a huge difference for low and middle income countries. And in addition to your question on vaccine production, I also just want to finish with sort of an optimistic note that, you know, we are learning so much about dengue. Awareness is increasing because of the outbreaks everywhere. And I think it's an opportunity for us to work together on getting more support for dengue control. And we have tools available now. We didn't have effective tools available before. So Wolbachia replacement and the new dengue vaccines, I really think create an opportunity to strengthen dengue programs in countries.
Thank you. I think that is just a wonderful point, Gabriela. And I, you know, I said this when I talk about dengue. I've learned more about dengue from the dengue vaccine studies than I learned from a textbook. We've learned so much from these vaccines, and I think it's key that, as you say, that we continue to learn and that we communicate. We didn't really have a lot of time to talk about communication, but that's going to be key as these vaccines roll out. Just about the safety and the disease and everything. And I too am optimistic. But I really just want to thank our panelists, who I think did a fantastic job. Thank you so much, Jackie, João, and Gabriela, for a wonderful discussion. We could go on for hours, but I think we all have other things that we have to attend to today, unfortunately. But I want to thank everybody who attended and asked questions. If there's any additional questions, I think you can send me an email and I can try to answer them or send them to the person who I think is most knowledgeable about that. But thank you, everyone. And I don't know, Kamal, do you want to have some closing words?
No, I mean, just want to thank the panelists and you, Anna, for this very, very interesting session. And I think from the list of questions we had from the chat, it really shows that this is a hot topic for many of our colleagues from ADVAC. I just want to say that this recording will be put on the ADVAC Alumni website, so you can look at it again, and including the presentation. So please don't hesitate to have a look at that. So thanks again to all, and have a good day, evening, morning, wherever you are. Thanks a lot.